Welcome to Women Mastering Midlife, where we dive deep into the rich complexities of womanhood in our middle years. I'm your host, Victoria Byrd, a pharmacist, certified women's health coach, and your guide on this transformative journey. Whether you're navigating perimenopause, thriving in menopause, or mastering midlife's many transitions, this is your weekly dose of expert guidance, compassionate support, and a judgment-free space to explore it all. Here, we're empowering women to master midlife on their terms, reclaiming our health, our happiness, and our power. Together, we'll rewrite the narrative around this remarkable stage of life, from something to dread into a beautiful, bold transition. I'm so glad you're here. Today's guest is Christine Farrell, a respected leader in the field of hormonal health, over 2 decades of experience treating men and women navigating hormonal imbalances. Christine is an associate clinical professor at the University of California, Los Angeles, and an alumna of the institution as well. She is a member of multiple leading organizations in the menopause and hormone therapy space, including the Menopause Society, the International Menopause Society, the European Menopause and Andropause Society. She's also certified in Pellet Hormone implant therapy. Christine's practice, Bioidentical Wellness in Westlake Village, offers a unique integrative approach that blends conventional medicine with alternative therapies. Her focus is on individualized care, addressing not only hormonal imbalances, but also the nutritional, physical, and emotional needs of each patient. She's a passionate educator, published author, and frequent lecturer on the topic of natural hormone therapy. In today's episode, we're going to talk about a form of hormone replacement therapy that sparks plenty of discussion: pellet hormone therapy. While not currently included in the Menopause Society's official HRT guidelines, it is a therapy many patients are curious about and some providers strongly advocate for. We're going to dive into what pellet therapy is, how it works, and where it fits into the broader conversation about hormone support in menopause and beyond. Thank you so much, Christine, for coming on and talking about this. Some say a controversial topic, some say not so controversial, so I'm excited to get into it.
Thank you. Thanks for having me. And actually, I would agree with you. I think it's become controversial. It probably doesn't need to be, but there are reasons that I think it is.
Awesome. So we're going to get into that. But first of all, I'd love to know a little bit about what brought you into the realm of hormone therapy and your practice.
So I was originally doing internal medicine, but being a female, I had a very large female base. And I'm old enough that when the Women's Health Initiative struck in 2002, I was already practicing, and I watched all of my female patients who had been on hormones doing fantastic suddenly have horrible pain and crying and brain fog and, every symptom under the sun because they were ripped off their hormones. So it led me to start investigating, okay, what else can we do to help these women? And then led me to more natural, I use everything, but more natural ideas and options at that time. And also just a lot of research because it's not something that we're taught in school. So
you've been working with alternatives for the last 2 decades, pretty much.
Yeah.
That's amazing. And your patients have seen support and symptom relief and all the things that I feel like nowadays we're hearing isn't available in these alternative forms.
It's harder to get them in these alternative forms. It started out with, let's give you some black cohosh, and that wasn't quite cutting it for women. And then I was lucky enough to know a now retired nurse practitioner who was working with one of the large compounding pharmacies in the country. And basically, they helped to educate me at the time because, again, it's not something that anybody ever teaches you about. So, that's kind of where the alternative side for me began because I had been trained straight, FDA-approved, standard medications, and that's all we had.
So what exactly is pellet hormone therapy for those of us who have heard the term but don't really understand what it is?
So pellet hormone therapy is taking the same components that are in the patch, say, for example, like 17-beta estradiol, which is in your FDA-approved patch. It's done by different pharmacies that compound them sterilely under, 1,000 pounds of pressure in a sterile environment. And they take the same powder and they put it into a pellet. So a pellet looks kind of like a tiny grain of rice or a Tic Tac, something along those, lines. And the idea is that implanting it under the skin in the subdermal tissue where there's a lot of blood supply allows 24 hours a day of a small amount of hormone release, similar to what the ovaries would be doing. And they last anywhere from 2 to 4 or 5 months, depending on the patient. And it's just a small continuous amount. So when you're exercising, you're getting more because your blood flow is faster, which is similar to what the body does. So there's theories that it's more physiologic, and it's definitely easier. And for those women who don't absorb well through the skin, whether it's patch or sprays or et cetera, it's a great alternative in my.
And so which hormones do you provide in the pellet therapy hormone type? Well, I'm sorry. Which hormones are in the pellet therapy that you use?
I use testosterone and estradiol. There are progesterone pellets. I've tried them, didn't find that they were as effective as just doing the oral, but I do the testosterone and the estradiol. And they come in multiple different dosages. So it's not, you and I have seen in the menopause space a lot of talk about this super physiologic dosing of testosterone, but there's really low dose and there are really high dosages. And there's people who, do that, which I disagree with.
So if a woman were to come into your clinic and say, I want to try this hormone therapy, what is your approach to the beginning of a treatment?
Okay, that's a good question, because being that a pellet lasts in your body 2 to 4 months, I'm not going to start with something like that, because I need to find out each woman or man is so individual that you obviously want to make sure what's the right level for them. Where do they feel good? How is their absorption? And not everybody wants to have a pellet inserted every 3 months. So we usually start with blood work, kind of find out where they're at, and then put them on something that's adjustable, whether it's a patch, whether it's a topical compounded cream, kind of finding the sweet spot. And then if they say, okay, now I want to do pellets, I go, okay, now I know where you feel good, and then I will do pellets for that dosing.
Okay. So it's not just you walk in and all of a sudden you're walking out with a pellet implant that very day.
Not at my clinic. I know that there are a lot of clinics out there who are doing nothing but pellets. And just a quick note on that and why I think pellets got such a bad name is there are a lot of companies that are now doing they're recruiting doctors doing these weekend clinics. So say they'll fly you to Texas, all expenses included, wine and dine you. You learn how to do pellets over 2 days, and then you sign up to be one of their quote unquote providers. So, and I won't mention any names because I don't want to do that, but that is a problem because you're not, you're somebody maybe who, for example, I know a rheumatologist who started doing that. Well, he's not trained in hormones and hormone balancing. So that's great that he wants to help women, but the problem is that he doesn't understand the nuances of how to do hormones. So he went to his 2-day, thing, and now he's popping pellets in women, and I'm seeing a lot of the fallout from that. So that's, I think, why we see such a backlash about pellets, because it has become this kind of pop-up money grab sort of a thing. So I think that's disappointing to me because it's ruining what could be great for a lot of women.
Yeah, I see that in the health coach space. I mean, you could sign up to sell a workout. I mean, I don't know if they still do it anymore, but there used to be a big company that you would sign up to sell their shakes and their workout programs, and you're a health coach. Yes. Where there's no training, there's no education about behavior change, there's no parameters on what's safe and what you should be suggesting. And so that was always very frustrating for me. And I felt like it gave those of us who have gone and done the work and do try to practice, have a health coaching practice in the parameters of safety, it kind of gives us a bad name. So I definitely can relate to that.
Yeah, I agree. I mean, and I know exactly what you're talking about because I still see that even out there with the whole, anybody can call themselves a menopause coach, right? Or a life coach or a health coach. But, there's people like you who have a background, who've done the work. And I feel the same with pellets. It's like I trained to do pellets over 15 years ago with a breast cancer surgeon who's, very, very well versed and has an ongoing research project about using testosterone in breast cancer survivors. And then there's these pop-ups that come in, and you've got every doctor who, granted, I understand they want to make money or they need to in this space nowadays, but it's dangerous for women and it's giving it a bad name. So now, it's like this, I get attacked online when I talk about pellets because people say, oh, you're just in it for the money. It's a grab. It's dangerous. And I'm like, not if you do it right. It's really not.
Yeah, I know a few colleagues in the space that I've talked to about pellet therapy. And I've said, I want to talk to somebody on the podcast about it. And I want to really understand the nuance behind it. And she was like, I don't know if you're going to find somebody who will openly discuss it because there's so much backlash around the topic.
Yeah. Yeah, it's something that I'm passionate about because I will tell you on a personal level, I have tried every form of hormone therapy personally. Topical, patches, gels, you name it, and it doesn't work. I don't absorb well. I have migraines. Patches give me horrible migraines because of the fluctuation. There's a bell curve with putting a patch on and then taking it off. And the pellets, I've been on pellets personally for over probably 11, 12 years now. And even recently, I thought I'm going to try something different. And I felt horrible. I feel great on the pellets. I feel like myself. I feel happy, healthy. Do I love having to get a pellet every 3 months? No, but is it worth me feeling great every day? And I have no osteoporosis. I have no problems. I'm in great health and feel fantastic. So I feel like if I didn't have that option, I don't know what I would do. I really don't. So, I understand that it's not for everybody. And it really, really needs to be done by somebody who understands hormones, not just how to stick a pellet in somebody. That's easy.
Yeah, it's really interesting that you talk about the bell curve and the hormones, especially when you're talking about like the exercise and the increased vascularization of the area where the pellet is. I'm a patch user. I've never tried pellets. And I actually stopped using the patch for a while because I felt like it was making me feel just miserable. And my dose, I had to keep changing my dose and fighting with the levels. And in perimenopause, I felt like now I'm to the point where my I'm going to get really personal. My cycles are a lot longer now than they were before. But when I was having a period like every 5, 7, 10, and I felt like in the beginning when they were really short cycles, my hormones, I couldn't handle my natural hormone fluctuations and the patch at the same time. And now I've gone back on it and I can tell you, because you're supposed to change it twice a week, it's really weird because it's not really every 2 days or every 3 days. Yep. And so you get to the end of that patch cycle when you're about to put a new one on and you can tell the difference.
Yep.
And I can also tell the difference when I put a brand new one on.
Yes, because it ramps up. And the patch was designed to be every 3 days, but insurance only covers it twice a week. So like you said, there's 7 days in a week. That kind of makes it difficult. So I always tell my patients, try to do it at 3.5. Try to do one, like a morning and then an evening and try to do the best you can. And I've even fought with insurance to try to get it where people are getting it officially every 3 days. So it ends up being like 1 or 2 patches extra a month. But it's that significant of a difference for people. And I've noticed, like if I put it on, because I'm such a sensitive person to migraines and estrogen fluctuation, that when I first put the patch on, I'll have a migraine within 4 hours because of that, uptake of the estrogen. And then really badly at the end of it. So I thought this just doesn't, unless I was popping a patch on, like you said, every 2 days, it would never work for me. And then, I've tried some of the the compounded topical. It doesn't get through my skin. I don't know why, it just doesn't. And I think that's important for people to know too, that not every woman absorbs transdermally real well. And not a fan of oral for multiple reasons. I mean, there are some orals out there that are great. I use Bijuva in patients because I do feel that that's a good, safe, FDA-approved product that's oral. But there's just not a lot of options. So I feel like pellets are a great option. And I will tell you, and I don't make more money off of pellets because I know I get, people attack me online for, oh, you're just doing it for the money. I don't make more money because it's the same amount of time that I allot for any patient. Now I'm also paying for supplies, etc. But the reality with my pellet patients is they are actually my happiest patients. They're very stable. They're very happy. And when it comes to libido, I've never found anything that works as well consistently. So it's, this is just my many years of clinical experience. So that's why I like them. I do say that as far as bleeding goes, and I warn patients, if you have a uterus, it's not always the greatest way to go, because when you've got that continuous release from the pellet, the pituitary is sensing that. So the FSH tends to drop, and then the body goes, oh, look, I'm 20, I should have a period again. So there's a lot more bleeding in those women. So it's not the most ideal for women who have a uterus. So I'll throw that.
Okay. Okay.
Yeah.
That's good to know. And that also shows that you don't just put them in every single person that walks into your clinic.
Never. No, definitely there are some that are, somebody who's very sensitive hormonally, or who's still, perimenopausal and getting some ups and downs. I will say that is not for you, because they'll come in, I want a pellet, and I'll think, no, you got to let's see how you do. Let's see how you feel. And then we can decide if that's something down the road that is worthwhile. And quick thing I just wanted to throw in there. People think pellets are some new thing. They actually were developed in the 1930s and came to the United States in the 1940s. So they were one of the original forms of hormone therapy ever done. And when the pharmaceutical industry came out with other things like Prempro, et cetera, then obviously they kind of fell off the grid. But they go back quite a long time. And there is, FDA-approved pellets for men called Testapel. So it's not that pellets are this new, wild thing that's come out. It's been around a long time. It's just, it's being used, I think, in some cases improperly, which then gives it a bad name. So.
Well, and I think, I've learned a little bit more about the FDA process. And just because it's not FDA approved doesn't mean it's not researched. Correct. Or tested to be safe and effective. It's just that the FDA process itself is so very costly that it costs too much money for some to produce the FDA approval, but also drug companies may not find the volume or the profit in getting that FDA approval.
That's a very good point, because, if you're looking at something that's going to be widespread use, then yes, they're going to put the money into it because it is very costly. And then on top of that, you have to look at the fact that every woman does not get the same dose. So the tricky part with FDA approval, right, is that if I'm looking at a pellet, I'm going to do my studies on a particular dose of pellet in order to get my FDA approval. And that's not the point of doing these pellets, is that, it's really meant to be individualized. Same with compounding. I mean, I know there's good compounding labs and there's bad compounding labs, and there's bad, there's not regulation, which I wish there was a little bit more, because then there wouldn't be the fear mongering. And that's the same thing with the pellets. I mean, I use a particular company that's been around for a long time, has high standards, does quality control testing. But, you and I both know there's been stories of unsafe compounding. Yeah.
Well, and for compounding, I think that also gets a bad rap. I know when I was in pharmacy school, compounding lab was not my thing. That was terrible. I would come in and my products would be, a liquid would turn to a solid overnight, or my suppositories, I would touch them and they would crumble. I'm like, well, clearly this is not my forte. We'll leave it to somebody else. Yep. But there are, there's for every Tom, Dick, and Harry compounding pharmacy that has technicians compounding, or pharmacists who maybe shouldn't be or aren't really measuring correctly, there are compounding pharmacies that have very strict regulations in their company, and they have very strict policies, and they have the equipment to make sure it's precise. And I think that that's where the compounding might get a bad rap. And I will be the first to say that probably when I first started in the menopause space 4 years ago, I was very anti-compounding. I will say it. It was a hill I would die on. And the more I've learned about compounding pharmacies and their practices when done right, they can actually really benefit women.
Yeah. Yeah. And, pellets are compounded because we don't have, official pellets for women. Now, could I use a 75 milligram Testapel on a woman? I could. That'd be higher dose than I frequently would use testosterone wise. But, and it's not going to be covered on insurance, and it's going to be way, way, way more expensive for women, unfortunately. So I feel like compounding right now in the world of menopause, and this is, where pellets fit in as well, is an important option because not everything's covered. There's a lot of problems with insurance coverage on on medications for women. And, we need options, and the ability to titrate somebody who needs a really low dose or something different than what's out there that's FDA approved is helpful, because otherwise you're leaving a huge group of women out that can't tolerate those things that are FDA approved. And then there's testosterone. We don't have FDA approved testosterone. So the pellets done right, I mean, I've had patients tell me that they've never had a great sex drive since, perimenopause, and they get on pellets and all of a sudden their husbands are becoming my patients because they need to keep up with them. So it's, there's definitely improvement in quality of life, and safety is always at my utmost, but it doesn't have to be, you don't have to sacrifice one for the other, basically, is my opinion.
Yeah. Yeah. So since you said the word testosterone, I want to get into that, because I think that the FDA approval for female testosterone is just so overdue.
Yes.
Because I think having an insurance covered product for testosterone would really help a lot of people. And I know I haven't worked in a retail pharmacy in quite a while, but when I did, the only thing that was available were packets of male testosterone. So it would be off-label use. It would be over a 30-day supply, because you'd have this massive amount, or you would waste.
Yes.
You would tell somebody to use a tiny bit of the packet and toss it, or they're using a tiny bit of the tube, and then it's past the day supply, so they're having to pay out of pocket, or the insurance won't cover it.
Yeah.
And it's a controlled substance in the United States.
It is
and
now,
so then
yeah.
you have all these controlled substance regulations that have actually gotten much more tight since I was practicing. And so then you have, well, I can't give you more than X day supply because of constrictions with the law. And so women are frustrated with their pharmacists and their pharmacies, because they think, I have this prescription. Who are you to tell me I can't get it? And then our hands were tied. And so I think that there has to be a better solution. And so testosterone pellets sound to be like an option for women. It's not going to be covered by insurance, because it's not FDA approved, obviously, and it's not an indicated use for women. Thank you,
Yes,
United
right.
States healthcare.
All right. Yep.
But and then I've heard these massive stories of, oh, this patient came to me that had testosterone pellets, and their voices deepen, and they have clitoromegaly, and there's all these scary things that have happened, and they can't reverse it. Can you tell me a little bit about how you found testosterone pellet therapy to be safe and effective?
I think you hit the nail on the head. There's a lot of these, pop-up companies that they'll do a very high dose, because, okay, sometimes women feel really good when you give them massive amounts of testosterone. Their energy's back, their sex drive's amazing. But yes, then you have hair loss, hair growth in places you don't want it, clitoromegaly, deepening of the voice. I have seen this in my own practice. We've taken over a number of patients that have come from other providers who are having those issues. And what's heartbreaking to me is that these women want so badly to feel good that they were tolerating. I've seen women wearing wigs because they've lost so much hair. I've seen women with, hair growth all over their gluteal area, tolerating it because they felt better and they thought it was their only option. And their provider was giving them super high dose testosterone. So were they feeling kind of better but having these major side effects? Yeah. And they thought this is what they had to tolerate. So I think that comes from lack of education and understanding hormones, obviously, on the provider's part. So that's why I say pellets, number one, aren't for everybody. And number two, it is really important that the person that does your pellets understands hormones and menopause and what are actual safe numbers for women. Because when we dose testosterone, even if we're using like an FDA-approved product that's meant for men, we still sometimes will see higher than quote-unquote normal levels in our patients. And it doesn't have to be harmful, but there is a point where definitely it can become very detrimental. And I think it's wrong.
If you're navigating the maze of perimenopause and wondering, is this normal? You're not alone. My free guide, Menopause Science and Symptoms, breaks down what's happening in your body and why. It's your roadmap to understanding the changes and embracing this phase with confidence. Download it now at missvictoriabyrd.com/free guides and take the first step toward empowered wellness. You'll also find the link in our show notes below. Be sure to sign up and grab that free guide.
So what is your approach to testosterone replacement for women?
I usually start with a topical compounded. That's my normal. And I'll start very low dose, like, a milligram at the most a day kind of a thing. And depends on the woman. And sometimes I work up, sometimes I work down. It really depends. And then those that say, I'm terrible with the cream, or I'm not absorbing the cream, or I want, I want to do the pellets. That is when I would put somebody, and I always say, I'm going to start you conservatively, because I can always give you more. I can give you a topical, I can give you whatever, but I can't take it out once it's in. So I think that's the concern, is that a lot of women, and I get this in comments online when I talk about pellets, somebody will say, oh, I went to such and such a, company that just pops pellets in everybody. And I had this horrible experience, and I was bleeding and I was growing hair everywhere. And that is sad to me, because now they're not only afraid of hormones, but they're not going to trust the providers that are out there. It definitely gives pellets a bad name. So I think that my theory is start low and work up on anybody. And not everybody needs testosterone. I do blood work to start out with. That's something, again, that's controversial, but I really feel like we need to know where our baseline is when you first see a patient. And then you need to do blood work to see if you're getting absorption, because I can do 3 different women on the same, FDA-approved progesterone capsule and have levels that vary from 0.5 to 25 in the bloodstream, in the serum levels. So it really helps me to determine, oh, this is why you're struggling. Yes, I've got you on this dose, but you're not absorbing. Or, wow, you're hyper absorbing, so therefore we have to do something different.
Yeah, I think there's some, I feel like there's this push. I mean, I think and I believe that you don't need to treat perimenopausal symptoms with hormones based on labs. Like, you can start based on symptoms.
Yeah.
But saying that you shouldn't test for hormones is a completely different thing.
Correct.
And I feel like the messaging has gotten skewed out there that you shouldn't ever test for hormones, or that it's not necessary. And if your provider says, I want to get your hormone levels, then, oh my gosh, they're wasting your money and your time.
Right. Yeah. And blood work's covered on insurance. I'm not out there doing crazy alternative testing. Go do, these fancy tests, these urine tests that you send. I don't do any of that, because we have good testing that's covered on insurance. When I do my blood through my insurance, it's $40. So it's worth it to me, because sometimes in hormones, sometimes symptoms kind of overlap, like high estrogen, high progesterone, different symptoms will look, say, migraines. I'm getting more migraines now. Well, there's multifactorial issues there. So sometimes looking at it and going, oh, wow, you're not absorbing your patch very well. So and I've got you on such and such a dose of progesterone and you're absorbing that really well. That's where blood work helps me. I agree in perimenopause. It helps sometimes. I actually had a patient about a week ago who had been told she's in perimenopause, told that she doesn't need hormones, and came to us, and her hormones showed that she was actually very, very low on estrogen and progesterone, still getting some cycles, but across the board pretty low. So putting her on a little bit of hormone based on the blood work, like, oh, hey, look, you really do need something, and you do need probably estrogen as well as progesterone. That to me is where it's helpful. That you can look again at an individual, but I agree with you. Sometimes you can go, all right, well, your cycles are wonky. We need to put you on some progesterone, cycle it, and help you, that sort of a thing. And work with, like what you would do, diet and exercise and lifestyle changes and things like that. I think that's massively important. Hormones are not a cure for everything in every person. I think there's a lot of factors. And if somebody comes in with libido issues, there's a lot of factors in that for women in particular. So it's looking at the entire person. I think that's, at the end of the day, it's not just saying every person who walks in the door gets a pellet, and you might, it's kind of like throwing a dart and going, maybe I'll hit the target and maybe I won't. That's how I look at it.
Yeah, I think it's silly to ignore that hormones affect things, but it's also silly to ignore that you're stagnant in your day, you're not getting movement, your diet you're not eating enough, or you're eating the wrong things.
Yeah.
You're drinking alcohol, you're stressed, you're not doing anything to mitigate your stress. There's so many compounding factors that we're not paying attention to. And I have found that a lot of times giving women permission to rest, to say like, these are things I'm going to let go, and getting permission from somebody outside of themselves to put things down, it's amazing how much better they can feel. Or even just adding movement to their day, they sleep better.
Yeah.
And so there's a lot of factors that people don't take into account. And you're right, a hormone patch or a pellet or anything isn't going to just fix everything. It's not a panacea.
I agree 100%. And I think that we live in a society where we want a pill, we want a quick fix for everything, like hurry up and make me lose weight or make me feel better. And there's definitely a place for medications and hormones. I would never say there isn't, but I think they have to go hand in hand with diet, exercise, stress reduction. Like you're saying, I'll do it almost as a prescription. Like I want you to start taking a walk, stop going to boot camp every day, and learn how to de-stress and do things that are restorative for your body, that kind of thing. So,
yeah. I mean, I've never seen more success for women than taking a walk every day. I mean, they're going a mile a minute, and walks are good for your body movement wise, but they're also good for your brain. Yes. And just your overall well-being. And it's so underrated in our driven society, especially in this country. Everybody that I've taken, like my clients who they go to Europe or they go to even Disney World, they're like, I walked like 15,000 steps a day. And even though I ate Dole Whip every day, I maintained my weight, and I slept really well, and I felt really great. Yep. Or I went to Europe and I ate pasta and all the things that I don't eat at home, and I still felt better, and I actually lost weight on that vacation. And yep. It's like, well, sometimes you have to look at your step count.
Exactly. No, I think you're right. And I live in California. Nothing's close to one another. So there's a lot of, get in your car and go to the store, get in your car and go here. And we have to force ourselves to go outside to take a walk, because it's more the like, oh, I've got to squeeze in my workout. I'll go to the gym for 45 minutes while I sit on my butt on my computer all day long the rest of the time. So I agree with you. And I think that we need to talk to women more about that. And that's where your space is really important. Because I get women to come in and they're mad that they can't lose that last 5 pounds. And I'll say, how much wine again are we doing every night? Oh, well, yeah. But I'm eating really, really well. And I'll go, but those 2 to 3 glasses a night, you drop those, you drop that kind of thing. And the hot flashes will get better, and this will get better. So, yeah.
Yeah. Oh, I mean, there have been times I've sat there with a cocktail looking at it thinking, are the night sweats worth this? Is the poor sleep worth this? Like, I really have to, sometimes it is, but sometimes it's like, no, yep. I'm at that age where a good night's sleep is so much better than that Manhattan. It's just,
it's so true. So true. I always do that after a bad night's sleep, after having a drink or two. I'll go, why do I do that? Well, spend at the time. But yeah, now I'm going to pay for 2 days, not for just a morning,
Yeah. Yeah. And I've read studies, and every study you read, somebody can negate it with something. But I do kind of understanding physiology and the way the body works. It makes sense to me that when you tell women, when you have alcohol, your body's first process is to detox that alcohol out of its system. And so if you're trying to burn fat, the first thing your body's going to do is detox your alcohol. So the time that your body is getting the alcohol out of your system, you're not fat burning. So that's another trade-off. And a lot of women, they'll be like, I don't care if my sleep is bad. But when you say you're not burning fat, like all that exercise you're doing in the morning is totally negated by the alcohol consumption in the evening. Then they change it and they're like, oh, wait, I'm not as puffy and I've lost that stubborn 5 pounds. And, so there is something to be said for diet and lifestyle. And I think that goes hand in hand with hormones, and the fact that if hormones help you sleep better, yes. Or if they're reducing the night sweats and the hot flashes, and you can get that quality sleep again, then there's energy to exercise. It's such a vicious cycle.
Oh, I completely agree. And actually, I'm going to use that about the detoxing your alcohol. Thank you. That's a good one. I'll use that in my practice because it's true. But no, I agree with you. It's, and it does get harder as we get older. I mean, when we're in our 20s, we can go out and party with our friends and bounce back in the morning. And, it's not that big a deal. But as we get older and we're in menopause, we're not processing things the way that we used to, period. So you have to kind of make a decision of how are you going to take care of this body. And, that's where I think hormones, there's all the controversy with hormones, because some people say, oh, we don't need hormones, we just need better lifestyle. And I disagree, because we had the hormones our whole lives. We need to replace them, but we need to do the other parts too. We can't just do one or the other, in my opinion.
Yeah, so they do go hand in hand. And I think that knowing that there are practices out there that offer, you're not just a pellet clinic. The fact that you don't even start on pellets, that some people aren't right for pellets, it's a tool in your toolbox as a practitioner that you're using to offer options.
Correct. And I think that's an important thing that people need to look at. It's not, you need to have all the pieces or all the tools that you can in your toolbox to help a woman. So I may have tried, and this has happened before, start with a patch. Patch doesn't work for a person. They don't feel well. It doesn't matter what dose. Try compounded, not absorbing. Okay. Now I'm starting to run out of options. I'm going to try the one oral that like I told you, that I think is safe, and I'll work with that. Not feeling good. Okay. Or again, absorption is wonky. As I said, I'm the perfect example, because I feel great on pellets, but I don't feel good on anything else. I've tried and tried and tried, and it just doesn't work. So I go, okay, well, I guess this is what I'll do until they come up with something better. But at least, thank God, I have that tool so that I can feel good. And I have a lot of patients where it was the same, and they're very, very happy with their pellets, and others, it's not for them. I've had patients that did want me to give them pellets, and we got to that point, we did it. They didn't like it. I took them off, and they're on other things now. They're doing great. So to me, it's just about looking at each woman as an individual, what she needs, and then taking the proper tools that you have and using them to help that particular patient. So it's not about just, cranking out a bunch of people on pellets, because that's easy. And I've seen these clinics. I've actually gotten my hands on their algorithms, and it's kind of sad, if this, then this, and this is your dose. So you're not being looked at really as a person. You're just getting, a pellet thrown in you, whether you really need it or not. And then you've got, again, somebody who's bleeding, and now she's got all these issues, or she's losing hair, or her voice is getting deep, and and they're scared, and then their gynecologist is upset, and it's giving hormones a bad name, and it's certainly giving pellets a bad name.
Yeah, and I think way back, if I can go into my dusty vault of memories, pharmacy school, when we were in our therapeutics class, it was when you were taught a disease state, there was, if the cholesterol is this level and this blood work, the liver's functioning fine, they start on a statin. Or they have high blood pressure at this level, you start at a hydrochlorothiazide, and then you go to an ACE inhibitor. And so there's all these little funnels that you put people in based on labs or values of things and metrics, and then there's monitoring, and then you readjust. But that's not the way you have to handle menopause. And I think that traditional medical training doesn't allow you to see the person instead of the lab work or the chart.
Yeah, agreed. And I think when we stick to everything has to be, we only have these things to work with because they're FDA approved and there's no other alternatives, you're handcuffing providers and patients because, okay, so for example, if I've got a patient and her insurance is not covering her hormones, and it's going to cost her $100 and something a month, and she can't afford that. Well, I can do compounding where it costs her $50 or less, and I can make it last 2 months. So it's an option for her where it works for her, works for me. It's safe. I'm monitoring her. I think it's really important that we look at the fact that we don't have a lot of fantastic options for women, and to say that those are the only options that are safe, I disagree with. And I always tell my patients, they'll go, well, pellets aren't FDA approved or compounding is not FDA approved. And I'll say, you have to remember that the core product in your compounded cream or in your pellet is the same as your FDA approved product, and then try to explain to them how FDA approvals work. It's not that the estrogen isn't FDA approved. It's that particular form of administration is not approved.
Yeah. And so when you, and I think one of the things that people also need to take from this conversation is that there's a lot of women who they get to the point of desperation, they go into the doctor, they want to get a prescription for hormones, and then come out and 3 days later, they feel amazing.
Right.
And you see people commenting like, oh, I finally got my hormones, and a week later, I feel like a new person. But that's not necessarily the case for everyone. And a lot of times it's a little bit of whack-a-mole trying to figure out how to dose, what route, what delivery system, coming back again and again. And I think women also need to recognize that it's okay to say they don't like the way they feel with something instead of just taking the prescription, leaving, and coming back in a year.
Yes.
You know, I mean,
Yes.
it's a more complex thing than that.
Yeah, I always tell my patients when I start them on something, I'll say, here's the possibilities, the good, bad, and the ugly. And I want to hear from you. If by any means you feel worse, I need to know right away, because you should never feel worse. If you're feeling nothing after a couple of weeks, then I might need to make some adjustments. And if you're feeling great, I'd love to hear that phone call too. So, you know, it's kind of, I like the feedback. And I have my patients typically, when I first start them on something, come back after about 3 months, and then sooner if they need to. That's my protocol. And then once they're feeling great, 6 months is usually our norm. But I feel like it is, I very much agree with you. You know, Suzanne Summers was a very, very controversial person in the hormone world. I'll give her huge props for getting menopause into the conversation. She really did a good job. But she even wrote in her book that it took her about 6 months to get dialed in. So I remind women that sometimes we get it right the very first time and you're feeling great in a week or two, but it definitely takes, you know, a little fine tuning for the majority of women until they feel good. So, you know, don't go, oh, that didn't work, and throw it in the trash and be done.
Yeah. And I feel like with perimenopause, especially, it's going to take more adjusting because you're still producing hormones in your body naturally on its own. And so it's hard to say that what you're doing now is what you're going to be doing in 3 years.
100%. Perimenopause is so wild. It's a roller coaster of hormones. So I always tell women what's happening this month may not be what's happening next month. And I try to actually teach my patients what the different symptoms mean. Like if you're having these symptoms, it goes along with high estrogen. If you're having these, it goes along with low, or, you know, you need more progesterone, et cetera. So reach out to me, but I want them to be educated as to what's happening in their bodies so that they can reach out to me and go, hey, I think this is happening and I think you need to help me with it. So I think that's a big part of it too, not just saying I'm the provider and I'm telling you what to do. It's like, let's let women be part of this process so they understand what's happening and they can do things to help themselves, whether it's lifestyle or reaching out to their provider and getting a hormone adjustment. I 100% think that's something that's lacking and that we need to be better about.
Yeah. Don't even get me started. I'll be off on a tangent for 20 minutes about that. So in reading your introduction, you're part of the Menopause Society and the International Menopause Society. Are there differences that you're seeing internationally versus in the great United States of America?
Yes, definitely there are. I follow the International Menopause Society's guidelines much more than I follow the Menopause Society, and I'm sorry because I'm a member, because that's the world's body of researchers. So you've got people from India, the UK, Spain, anywhere, and they're all trying to treat women and going, particularly when I've gone to the conferences and I see these different speakers, how differently they treat women in different countries, number one, how advanced they are in some countries compared to the United States as far as the use of hormone therapy and what they're using. Pellets were discussed. That's what got me so frustrated when the Menopause Society really came out hardcore against pellets, was that pellets were discussed at the International Menopause Society congress last time I was there. And they talked about the history of them and where they have their place, et cetera, et cetera. So I think it's a broader conversation with the international group than there is here. And the United States has typically, and the Menopause Society, or what used to be the North American Menopause Society, has always been much more conservative, which is good and bad, right? You don't want to just randomly give hormones, but I think we need to keep a broader perspective and an open mind that our way of doing things may not be the only way of doing things.
Yeah, I was thinking about just the idea that, there's pellet therapy and then there's pellet pushers, just like there's testosterone therapy in the pharmacy and the testosterone you would buy in a gym locker room. Like there's two different, there's two different ways to look at it.
That's a great analogy. That really is, because I treat men too, and I get guys that come in and they've been buying all kinds of nonsense from the gym. And, so they want to be on therapy, but they've been getting some scary stuff. And it's just the same as like these women who they want their libido to be better. Their marriage is suffering. And they hear that they can go get a bunch of testosterone. Their libido is going to be great. So they go to the pop-up clinic that pushes pellets, and they think that's their only option. Then it goes poorly for them, so then they're afraid to do anything else. But again, there's safe, effective ways to do this, and I think at the core of all of this, it's open-mindedness. It's doing it safely. It's doing your research. It's making sure that what you're doing is okay and safe and monitored properly, etc. But I get so frustrated with the black and white philosophy in the menopause world that there's only one way to do this, because that's not fair to women. It really is fair to women.
Yeah. And I also think you touched on a little while ago, I like to just go on different rabbit trails every now and then, but you were talking about the fact that libido is complex for women. And I think that that's another thing that we forget to talk about, is that it's not just the testosterone deficiency. There's issues with your partner. There's issues in your stress levels, in your happiness with your own life. And then, women's sex drive is so complicated. Yeah. And I think that we're forgetting that piece too, in that, okay, so you get testosterone, but you're still not interested in sex. Well, there might be other things at play.
Exactly. And we talk about that a lot in my practice, because there's been some great research in the past few years about women's sexuality and the complexity of it, and the responsive desire versus spontaneous desire, where guys, the wind blows and they're like, hey, that sounds like a good idea. And us, It's like the stars have to align. I have to like you. It has to smell good. The kitchen has to be clean. There's all these factors that go along in our desire. And I always tell women, I'll go, okay, so when you're talking about your desire, do the parts work? Once you get going, are you feeling like your sensation is good and all of that is good? Yeah, that's great. And I go, okay, so that means your testosterone is working. Whatever you're getting, or your body's natural testosterone is good. Because that's the biggest part for me with testosterone, is the physiologic response. Does it affect your dopamine and your desire? It does. But that's a whole, like you said, that's a whole other ballgame. You have to look at all of the factors. And if somebody's like, the parts are working, I'm not going to give them super high dosages to try to get their brain to start jumping in. Because, when I went to do the training on pellets, it was mostly male providers if they're with me in the training. And this was a long time ago. And the female doctor who was teaching us said, high dosages, you can get hypersexuality, but you can also have hair loss and clitoromegaly and da-da-da-da. And the guys were like, I'll just put a bag on her head. I'm like, really? Nice.
Yeah.
So classic. Yeah. But again, so we can find a happy medium for women of give them a small amount of testosterone that does help their responsiveness, but then we got to work on all the other pieces for them, or help them understand what's normal, and that they're not broken because their brain doesn't want them to have sex all the time. We're not really wired that way. So,
yeah, I know. Well, and I think having the conversations that we're having, or that I'm seeing, at least my algorithm is giving me. I don't know if everybody is looking at the same things I'm looking at on social media, but the fact that we're even talking about hormones, and that women do run on, a standard 28-day cycle, whereas men, they're just the same every day.
Yep.
I think understanding that we are more complex human beings, and that we require a different approach in every aspect. I mean, I went to pharmacy school. Gosh, when did I graduated high school in 98, and I graduated pharmacy school in 04. Okay. So, that was WHI, like thanks to like all the Prem Pro that we threw out expired on the shelf, but I think that, oh my gosh, I just completely lost where I was going with. Thank you. Thank you.
Some hormone health.
I know. Clearly, maybe I should readjust my patch.
No.
But anyway.
We were talking about the male female
complexity.
differences.
Yes. Okay. Thank you. But the fact that I had no idea until recently that studies weren't done on most medication. I mean, there's the whole thing of like, women weren't in drug studies until 1993. I mean, clearly there were studies on birth control and hormone replacement that were done on women, but things like antidepressants, cholesterol medications, diabetes medications, all of those things, it was easier to just study it on men because they're classically the same every day. Whereas women, hormones can have a huge role in metabolism and all sorts of different physiologic responses to medications. And so it's easier. Yeah. But I think just knowing that, and how I'm hoping with women's research funding, hopefully increasing as women are getting more into the workplace and having a stronger voice in health reform, that we start to figure out the differences a little bit more.
Yes. It's a joke in our office that because I do treat men and women, I can see two men in the space that I could see one woman. And that's not the woman's fault. It's because men, lucky for them, like you said, they're pretty much the same all the time. And women, we're very, very complex. I mean, the hormonal fluctuations and what that does to us in the rest of our endocrine system, et cetera, it's very, very complicated. And we need to give ourselves a little more grace on that too, to understand that, it's not just easy and cut and dry for us. It really is complicated. And that makes us kind of cool. And, we can have babies and all that kind of stuff, but it does make it harder for us. It does make it hard for us. It's not to say that men don't go through their own stuff when they lose their hormones, because they definitely do. And that's a whole other conversation because, men don't talk about that typically. But, with women, it is challenging. And perimenopause is probably the most challenging time for women, in my opinion. It really is, because there's so much up and down. And just when you throw that in with the time of life and what's going on, I think that's a very, very
brutal.
Yeah, it's brutal. It is. And I always tell women, once you get to menopause, I promise it's going to be better. So,
yeah, it's like once the factory shuts down, it really does get better.
It does.
So, in the interest of time, although I would love to, I think we could continue this conversation and we could have a 3-hour podcast. I would like to make sure that the people listening want to continue to listen to the end. So, in the interest of time,
yes.
What is one thing that you want people to take away from the conversation around pellet therapy as we kind of close out today?
That pellets are a safe and very good option for the right patient done by the right provider. And that it shouldn't be the first line therapy, that really, it's a great option for women who need it, who want it, but it shouldn't be the first thing that they're given. And you don't need crazy high dosages of any hormone in order to feel good. So I think it's just really, it's a matter of, they're not unsafe. And I'm just so sad that women have been scared that pellets are such a bad thing, or that they have to argue online about, well, I feel good on pellets, and then get shot down by some of the providers out there. That's what's upsetting to me. So just remember that just because one person out there says it's great or it's not great, doesn't mean you have to listen to that. Do your research, find a good, safe provider who knows their stuff. So,
thank you. Yeah, I hope that in listening to this conversation, anybody who's thought about it or is interested in pellet therapy as an alternative, they now know that they should find somebody who is versed in it, who understands it, and goes about it the right way before they venture in. But that it is, if that is something they want to entertain, it is an option that's available, and it shouldn't be, the black sheep in the family.
Thank you. Yes, agreed.
Yes.
Thank you.
So thank you so much for coming on. I've really enjoyed our conversation. And I'm going to put in the show notes how people can find you on social media and in your clinic if they're local. And thank you again for your time.
Thank you so much, Victoria. It was great.
Thank you for listening to this episode of Women Mastering Midlife. If something you heard today resonated, I'd be so grateful if you'd share it with a friend who might need a little extra support on her midlife journey. Remember, small changes can make a big difference, and you don't have to navigate this transition alone. We will be back next week with more expert guidance and compassionate conversations to help empower you to master midlife on your terms. Until then, you can find us on Instagram at Women Mastering Midlife, or come connect with me directly at Miss Victoria Byrd. And you're looking for deeper connection and support, be sure to join us in the Women Mastering Midlife community. We'd love to continue the conversation with you there. If you've enjoyed this episode, please rate and review this podcast. It helps us reach more amazing women mastering midlife just like you. You'll find all the links from today's episode and ways to connect in the show notes below. See you next time.